Thank you, sir. So the next one would be the training required for an emergency and the code blue drill for the staffs. So as I already mentioned, code blue is one of the emergency procedure codes for an cardiopulmonary assets and life-threatening emergencies in any area of your hospital. It's a term used to alert the code blue team to an area where a person has a cardiac or an respiratory arrest. So any attempt at the resuscitation is always better than no attempt. The use of code is initiated to convey essential information quickly with a minimum of misunderstanding to the hospital staff while preventing a stress or a panic among the visitors of the hospital. A code blue will be initiated on all, as I said, could be a patient, could be a visitor, or at times could be your own staff suffering a cardiac or a respiratory arrest, showing the following symptoms of not responsive, no breathing, and no neck pulse. Right. The first thing what you need to do is have a good, effective code blue team. So, and code blue ideally has a first responder who identifies and then calls for the code blue. The second responder who comes and starts the procedure, the team leader, airway manager, medication nurse, recorder, IV nurse, security, or a hospital. So, is this how every hospital has to? No. So, there are over a million of different combination of code blue team depending on your hospital size, the staff structure, everything. So, you can actually take your own decision of setting up the team. So, as I said, the first responder will be the first person to assess the patient's responsiveness and then call for the help. So, though you need to assign the role for every of your team member. So, the airway breathing monitor, the defibrillator role, the medication nurse, the recorder, who's very important when everything is happening. One person has to record. The primary nurse, and the most important of all would be the code blue team leader. This role is assigned to the most competent ACLS provider available. A physician from the anesthesia or emergency medicine or internal medicine are charged in the team. If they are not available in our ophthalmic setup, we need to take up this role. A rapid response team leader or a physician is responsible for directing the resuscitation effort, and he will be running the code throughout the procedure. So, an effective leadership is one who designates a role to team members and directs their action, dedicates appropriate treatment as per the ACLS guidelines, and gives order to the team member, decides appropriate disposition of patient once the patient is stabilized. Before the patient attender, brief the patient's attender after resuscitation, make sure that the information has been passed to the patient's family members, ensures that one member is designated to record the event in the code blue team. So as we said, like talking to the patient's attender once everything is fine and recording everything is also a role done by the leader team. Okay, so a rapid code team assembly is very important, which leads to high quality CPR, effective code leadership, and this will lead to an improved patient outcome. So the effective code blue is developed by means of effective training. Make sure every team member is being trained in BLS and ACLS. The initial and annual individual team role training is also important for every hospital, and the personal training of the leader is the most important of all this. So who need to take a BLS and ACLS? A basic life support is intended to be for anyone who needs to know the basic principle of CPR, AED use, other primary models. So every staff of your hospital should be trained in a BLS, and the physician who's in charge or the doctor who's going to take up the lead role should have an ACLS training. So first decide, are you going to learn and teach your staffs, or are you going to seek an external agency's help in training? It's always better to go for an external agency. When you are going for an external agency, there are a lot of AHA associated centers which can give you the BLS or ACLS training. So it could be a blended model or a classroom training, whereas in a blended model, you have all the online materials which is available. You can go through the theory, read, and then go to the center and then get your done. Basically, it actually saves your time. Or you can have a complete classroom training, and end of the procedure you will be given a certificate which will be valid for 2 years. The BLS deals with the basic CPR and other cardiopulmonary emergencies like the stroke and cardiac arrest. ACLS basically is an advanced cardiac emergency handling procedure. So the IV therapy and the knowledge of ECG is all being taught in the BCLS ACLS courses. This is very, very important. And at the end of the training procedure, you can create a protocol for your own hospital. So you'll be given a certificate which is valid for 2 years. You can make the protocol, laminate it, and paste it in your hospital. Right. So as I said, the leadership has to be effective. So getting a leadership training is also very important for us, especially in a setting like an ophthalmology where you don't have a anesthetist running around all the time. So you need to be ready to take charge, your roles and responsibilities, and the responsibilities given to the staff should be regularly monitored. Ability to coordinate activities of the members is very important. You need to have a shared mental model. Good assertive communication is very, very important for a leader. So remember, in a communication, the message only communicated if it is both sent and received. Always remember, whatever meant is not said. Whatever said is not heard. Whatever heard is not understood. Whatever understood is not done. So only when a thing which you are telling is getting done, it means the communication is complete. So for that communication, we have lot of training modules which is required for the leader. Right. So we got the best of BCLS, ACLS. We got a good team. Is that all enough? No. If a CPR is performed infrequently, the knowledge and skills are lost within weeks of training. And there are a number of studies which have said an in situ training program every 3 months decreases the median time of a chest compression from 33 seconds to 13 seconds, and defibrillation time from 156 seconds to 109 seconds. So the regular scheduled mock codes is all that is required. So of course the practice makes us perfect, right? So the objective of having a mock trial is that you need to discuss the value of performing a mock trial to your staff, make them understand, and then do it on a regular basis. Discuss the importance of delineating the team roles. For example, you must have trained within a month. If the staff moves out, you need to bring a new member into the team and then train them, and the coordination among the members should be good. So that's one reason why you need to have a mock drill, right? Have a BLS mannequin, and have a protocol for doing the mock drills also. It could be once in a month, or it could be a fortnight also. If you have a day and night shift, you need to have a mock drill both in the day and night shift separately. Announce that as a real code. You can start this as a low fidelity. Low fidelity is like having one or two members, especially in a night shift, to help them. Or you can move on to a high fidelity where you can have a simulation, full automated simulation mannequin, and then go ahead with it. Both adult and pediatric scenarios has to be created and then done. Finally, all this is done and the briefing has to be done. In a briefing, you need to ask three main questions: what went well, what could the team do differently next time, any safety or an equipment concerns that has happened. Right. For this, you need to have certain evaluation metrics based on the performance, the clinical, or the equipment, or the soft skill. Anything you need to have a evaluation metrics, and the evaluation metrics has to be evaluated, and then the mock drill has to be completed. So mistakes are okay in a mock drill as long as it helps the staff to do better in the real life scenario. So participating in mock drills on a regular basis is a proven way to boost your performance. Mock drills train the staff to be able to react efficiently in a life-threatening situation when every seconds is counted. Ultimately, practice makes perfect, and performing regular simulations in a controlled environment can be beneficial for the staff and lead to improved patient outcomes. Thank you.